All right, so we are going to get going with our webinar today. I want to thank you all for joining us. We are going to be reviewing epidural steroid injection coverage and documentation requirements for Medicare as well as for WPS this morning. So my name is Rachel Wood. I'm one of the nurse analysts with Provider Outreach and Education at WPS. And I'm joined by my fellow nurses in Outreach, Mary Sue and Jennifer. They're going to be helping with monitoring our chat for any questions that you might have. And we are also joined by some of our medical review nurses that do look at these cases and these claims. So they're going to be helping with questions as well as we need. So again, any questions, as with all of our webinars, please send those to all panelists. And we should have some time at the end to answer questions live. If we do not get to your question today or we run out of time, because we do have a lot of information to go through, we will send any outstanding questions responses via email. Regarding materials, these are available on our website. So you can go to our live events page, find this webinar, and then download the materials, which is going to be the slide deck that I'll run through this morning. All right, so here we have our disclaimer. What our disclaimer tells us is that this is for educational purposes only, and keep in mind that Medicare does change their rules from time to time, so make sure you're looking at the most up-to-date official CMS communications for any changes to rules and regulations. We are presenting on how our guidelines stand today, but if, for any reason, something is updated, very quickly after we conclude our webinar, that does take precedence, and we will, update you as that happens, but just keep that in mind. Additionally, I am recording this, and we will post this on our YouTube channel to have you all be able to view it as an encore presentation later. So no need to record or photograph this yourself, because again, we will be putting this up as an encore presentation. Okay, so some acronyms here. These are just for your reference. I'm not going to go through them, but they are, just some of the standard Medicare and WPS acronyms that we'll use throughout our slides this morning. Okay, so here we have our objectives and agenda, so our planning goal for this webinar today. I'm going to start by talking about the coverage requirements for the epidural steroid injections. Then we'll go through some documentation requirements, and then finally end with some of the errors that we most commonly see and some common questions that we get from our providers. And our main goal with today is to help you all understand the information that is in our local coverage determination, help understand the documentation requirements we're looking for, and then identify some of those errors that we see on our medical reviews for this topic. So overall, come away with a good understanding of the coverage requirements, again, for these types of injections. All right, so I want to start by briefly talking about how I'm going to refer to them moving forward as ESI is defined. So ESI is a minimally invasive procedure, which is a steroid injected into a designated or targeted area with the goal of relieving pain. So these procedures typically involve the injection of a solution that contains corticoid steroids and an anesthetic, or sometimes both, into the epidural space, along with saline sometimes it can include saline as well. So the inclusion of biologic or other non-FDA approved substances in the mixture that is injected with these steroid injections may result in a denial of the entire claim. So we'll talk a little bit more about information in our LCD, as well as the Medicare benefit policy, Chapter 16, Section 180. So again, just to kind of double down on that, there are currently no FDA-approved biologics that are used as injectables into the epidural space or spine. And so again, including any of these types of substances in your injection may result in a denial of your claim. So those that might not be aware, biologics, they are a class of medication and are grown and sometimes purified from large-scale cells, cultures of bacteria, yeast, plants, or animal cells. So just kind of a little background on what we mean by biologic. All right, so moving into coverage indications. Our local coverage determination, or LCD, which is L39045, contains the indication and medical necessity requirements that must be met to perform this service. So these coverage indications are listed, so some of them are listed here on your slide and will be listed on the next couple slides. These come directly from our LCD. So missing documentation of the LCD requirements is going to be one of the most common denial reasons that we see on review, and we will talk a little bit more about that as later on into our presentation. We did include a link to our LCD here on this slide if you would like to take a look at that as I go through the presentation this morning. But again, this information is from our LCD that we have listed. So these are the coverage indications that our medical review staff will use when reviewing your claims. And if you are a provider of this service, it is important that you know how to find our LCD, that you make sure you review our LCD, and make sure that you are aware of all the indications as well as documentation requirements that are listed to make sure that that is reflected in your documentation when you bill for these services. So I do want to highlight some of the coverage indications on our slide. So starting with history, physical exam, and radiology or radiological image-based diagnostic testing to support one of the following. So we are going to be looking for documentation of one of the following. So lumbar, cervical, or thoracic radiculopathy, radicular, pain or neurogenic claudication due to disc herniation, osteophyte or osteophyte complexes, severe degenerative disc disease, producing a foraminal or central spine stenosis, or post-lunectomy syndrome, or acute herpes zoster associated with pain. So the documentation should reflect that this information applies to the beneficiary that is going to receive those epidural steroid injections. Okay, so a little bit more continuing on with coverage indications. The beneficiary must have radiculopathy, radicular pain, and or neurogenic claudication, as we just mentioned in that last slide. That is severe enough to greatly impact the quality of life or function of that specific beneficiary. So we will be looking for an objective pain scale or functional assessment that should be performed at baseline, so prior to the intervention. And we are going to be looking that that same pain scale is repeated for each follow-up assessment of the response of those injections. So consistency is important with this one. We do look for that same pain scale just to see you're measuring, the same thing, as some different scales have different, measurement styles, and so it's hard to show improvement if you're using a different scale from baseline and then the next appointment and the next appointment and so on. All right, so a little bit more about pain on this slide here. So we are going to be looking for documentation that shows that and supports that the beneficiary is experiencing pain duration of at least 4 weeks, and that they have the inability to tolerate non-invasive conservative care or medical documentation shows that there's been a failure to respond to 4 weeks of non-invasive conservative care or acute herpes zoster refractory to conservative management, that 4 weeks wait is not required. So again, this information is in our LCD and is listed under that coverage indication info. All right, so one of our pre-submitted questions that we received prior to today's event was, what are the covered diagnoses by WPS for epidural steroid injection? So I'm not going to review all of these, but they can be found in our local coverage article. So that is LCA A58777, billing and coding for epidural steroid injections for pain management. There is a list of covered diagnoses in this link, and we did include a link to that in your slide if you do want to click out to that to take a look. So again, I'm not going to review this list code by code, but it is this would be your reference to check that out. All right, so so far I've talked about some coverage indications in our LCD, what the LCD is, and then our LCA. So now I want to go into the documentation requirements in our next section. Some of this information is going to overlap with what I just reviewed regarding those coverage indications, but just keep that in mind. So if selected for a review, our nurse reviewers at WPS are going to be looking for the following information in the medical record, and that is all listed on our slide here. So documentation of the history and physical, physician progress note, physician orders, documentation to support 4 weeks of non-surgical, non-injection care, counting from the onset of that pain, so the start of that person's pain, documentation to support an exception to 4 weeks of non-surgical or non-injection care if that applies to that beneficiary, any applicable procedure reports, prior procedure reports that support the appropriate frequency of the injection as applies, radiologic imaging reports, and then the final 3 on our slide here are, documentation pieces that kind of go across the board. So any changes to the medical record, we would want to see a signature attestation added. Again, if that applies, the advanced beneficiary notice of non-coverage, if the provider thinks that this is something that WPS or Medicare may not cover, and then any additional records that support billing and the medical necessity of this service. All right, so a little bit more on documentation on this slide here. So again, as I mentioned, we are going to be looking for that history, physical exam, as well as the imaging. So these are going to be based on diagnostic testing that support those indications listed in our LCD L39045. Next on our slide here, we'll be looking for objective pain scale or functional assessment. So I've talked about this already, but we should be using the same pain scale that is done before the procedure and then after the procedure to continue the injections, to continue to show, I should say, the injections clinical progress. So either they're having a positive effect, they're having no effect on the pain, or the person's pain is actually continuing to increase despite receiving these injections. One thing to note in our LCD that ESIs are that are used to treat nonspecific low back pain, axial spine pain, complex regional pain syndrome, widespread diffuse pain, pain from neuropathy from other causes, or certain types of headaches are considered investigational and are not something that we would consider as medically reasonable and necessary. To refer back to this and these types of pain, this is listed in our limitation section in our LCD. So please keep that in mind and reference back to, again, to that limitation section for that complete list of things that would not be considered medically reasonable and necessary for epidural steroid injections. Additionally, we're going to be looking for documentation of the prior non-invasive conservative therapies that this person's previously tried and failed. There's no specific list on what those might be, but we are going to be looking for, either they've tried, what they've tried, why it didn't work, and, supporting that this next this injection is a appropriate next step. Injections within the frequency limitations. So these are, again, listed in that LCD under the limitations section. As a bit of a review, the limitations and the limits that we have in our LCD limit ESIs to a maximum of 4 sessions per spinal region in a rolling 12-month period. So genuinely, it would not be something we would also we would consider reasonably medically necessary to go to receive these injections beyond 12 months. If that does happen, that would need to be reflected in the medical record, and we would most likely provide a focused medical review for these cases. So more information on that and what we might be looking for beyond that 12-month period is in our LCD. And then additionally, other documentation areas or items that we would be reviewing for include use of CT imaging guidance with contrast, positive clinical response for those repeat injections. So again, why though using the consistency with that pain scale is very important. And then finally, we do not have this on our slide here, but one of the limitations that we may have, may cause a denial is if you're doing more than one spinal region in that same injection session. So it's not considered per our LCD medically necessary to do more than one spinal region in the same session. All right. So we talked about documentation, coverage requirements, and where to find these coverage requirements. I want to talk now in the next bunch of slides about our denial reasons and some of the top things that our nurses see during their reviews. So these are included on our slide here. So they include missing documentation, failed prior injections, timeline requirements are not met, failed conservative treatments, and then incorrect billing. All right, so starting with missing documentation. So as a provider of this service, we highly encourage you to go back and take a good look at our LCD, L39054, and review those documentation requirements. So in that LCD, we do state that it is required for coverage and must be reflected in your documentation to have the following information listed on our slide here. So pre and post injection pain assessments. I've talked about this a lot so far, but most often we do see providers only provide a pre-injection pain assessment. And we recently have had some providers that, are asking why a post-pain assessment is necessary. So that post-injection pain assessment is going to be required as long as that local anesthetic will have the immediate effect, and the steroids are going to have that long-term effect. So again, we're looking to see if that patient has immediate pain relief from the injection or not. Next would be missing MRI or imaging documentation to confirm the diagnosis. So those diagnoses are in our LCA. So we do need that diagnostic report in order to ensure that our coverage conditions are met and you are treating a condition that is supported in our LCD and LCA. So next on our slide here, so those imaging reports do sometimes get sent, but they don't include the confirmation of diagnosis that you're using and you're treating with those ESIs. So if you don't have that confirmed diagnosis on those imaging reports, the LCD requirement would not be met. So just keep that in mind. And then finally, missing or lack of documentation to support multiple ESIs. So our LCD does have specific information in there that talks about what documentation should be present to support repeating ESIs But an example would be, lack of documentation of the percent of improvement, or maybe lack of documentation of improvement or function from those previous ESIs. All right, so moving into failed prior injections. So this is the next common issue that our nurses see, and this also goes back to, kind of that lack of documentation issue for repeating ESIs. So when a prior injection has failed and a repeat injection needs to be done, it's very important that the documentation contains info about what the provider is doing to, hopefully make that next injection successful. Is have maybe they changed the injection approach, or have they changed the level that it is injected in? Is there a medication change that's going on? Additionally, what indications are there that those changes may lead to a successful injection this next time around? So this information should be included in those providers' notes, and would be something we would want available if requested during a medical review. Okay, so our next issue is timeline requirements between injections not being met. So our LCD does list specific indications to be met to repeat these ESIs. If a provider of the service documents significant improvement of that condition and that they're treating using, again, those same baseline measurements, same baseline scales that they did on that initial assessment, but does the injections prior to waiting a full 3 months between injections, services are going to likely be denied. So that is something that is included in our LCD limitations area in our, again, in our coverage indications. So on the initial injection, if the documentation does not support that the patient did not respond well, and there is not documentation to support a different approach or level or medication for a repeat injection within 14 days of services, the 14 days, those services may also be denied. So in either case that I just talked about, the rationale and the documentation of the medical necessity rationale for those repeating ESIs must be documented and must be, clear to our nurse reviewers. All right. So moving on to failed conservative treatments. So this is something that is very clearly outlined in our LCD, that we are going to be looking for documentation of failed conservative treatments. So, what were those conservative measures taken prior to deciding that an ESI is the best treatment approach for this beneficiary? Is there documentation of history of pain for at least 4 weeks? Is there a documented pain scale to show an objective and measure of this person's pain? And then what types of conservative treatments have been tried? Did any of those provide relief? Did they provide some relief? Was there no relief at all? And, is this information supported as well by objective and measurable documentation of improvement? Or, was there no improvement at all with these conservative therapies, and the pain scale did not, reduce at all with anything that's been tried to date? So additionally with this, if an injection needs to be completed, sooner, the documentation should support why, so what's going on with this person, and again, what has been tried and failed. All right, so this moves us into our last most common error, and the last one we have found is providers are not, billing correctly, so incorrect billing. And we have found that providers are not accurately billing their drugs, injectables, or, contrast consistently. So we've seen some numbers of inaccurately reported or billed medications and as well as contrast. I'm not going to dive too deeply into billing. That's not my forte, but we did just want to mention it today for something to be aware of. On some of the claims, the drugs or contrasts that are billed to us do not match the drugs or contrasts that are provided in the operative report that we receive. So there's a disconnect, again, from what's billed and what's documented that was used. Or another thing that we're seeing is that the units billed do not match the units that were stated as administered in, again, that operative report. So these billing inconsistencies are something that we have seen quite a bit. So just please be careful to double check this information to make sure that you're putting, the correct information in the notes, as well as, the correct information in that claim that's later submitted. Right. So, and again, if you want some more information on billing, we did include that link earlier in our slides to our LCA A58777. And so that will have some more details on billing for these claims. All right, so the final two slides are, we are going to talk about stem from provider common questions. So our first slide here, do epidural steroid injections require authorization? And we receive this question a lot. We also see this error done a lot. So I want to make it very clear, epidural steroid injections do not require prior authorization at this time. So the answer is no. They are not part of the hospital outpatient department prior auth list. And we do see that these are often confused with facet joint injections. The facets are part of that prior authorization list. I also think that there might have been a little bit based on some of the questions that we received prior to our event on, authorization requirements, et cetera. May have been some confusion as well, even just signing up today. But again, epidural steroid injections are not part of that prior auth list. We do sometimes see people put in for a prior auth request for facets, and then when our nurses read those notes, they actually see that the provider is performing and the patient is receiving one of these ESI injections. So that's another thing, if that you found yourself doing that and then you're getting these non-affirmed results from these facet requests, just make sure you know what you're submitting before you submit it. Save yourself some time, so you don't have to go through back and forth of why was for these, you don't need to put it, you don't need to go through that prior auth process. So make sure you're just double checking so you're not doing any unnecessary extra work. All right, and then our last slide here before we take a look at any questions is sedation for pain management injections. So this is something that we also got asked in our pre-submitted questions section. So in order for sedation of a moderate to deep level to be utilized during the ESI documentation, there must be very clear and concise rationale as to why this level of anesthesia would be required. Local anesthesia would be sufficient in most cases, and additionally, minimal to moderate conscious sedation is appropriate, but the use of deep sedation would be the exception, so not that norm. And this documentation, again, must be specific to that patient and show, why this amount of sedation for this particular person does need to be provided. So again, so I just want to kind of reiterate, and this information is in our limitation section, but the use of moderate or deep sedation or general anesthesia or monitor anesthesia care is typically unnecessary and is very rarely indicated for these procedures. So it's not something that we would consider medically necessary for those higher levels of sedation. That does also apply to patients that have, maybe they're scared of needles or they have anxiety related to injections. For those patients with those phobias, we would expect oral medications to be something that would be utilized. And in the event that those, again, those exceptional, unique cases do exist, you must clearly document, the need to provide sedation for that specific patient. So that is up to the provider. That rationale is up to the provider. So we don't have any specific examples that we can provide, but it does need to be clearly documented in the notes. All right, so common provider questions. I actually did kind of go through all of these we left a slide here if there's any outstanding questions for the pre-submitted questions, but I hope I've addressed all of them throughout our presentation today. So I am going to skip into our resource section. So here we again included a link to our steroid injection LCD, and then 2 links to talk about our portal guide. So if you're submitting documentation using that provider portal, we think that they're useful to know where those links are because we're talking a lot about sending in your documentation. So just wanted to make you all aware of some resources on how to use the portal. And with that, we do have time for questions. So I want to check and see if there are any questions in the chat.
Rachel, there was a question that came through that I answered to the specific person that asked the question, but I want to just pose it to the whole group. And the question was, is there a restriction on the providers that may do this injections, like a CRNA or an MD? And the answer to that is that services will be considered medically reasonable and necessary only if they're performed by the appropriate trained providers. That's how it's worded in our LCD. So as long as your CRNA is appropriately trained and it falls within their practice acts and their state practice acts, so you'll want to check, per your state that it's allowable under their practice acts, then yes, the CRNA would be considered an appropriate person. So I just wanted to put that out for the whole group. I do see another question came through. Does the MRI or imaging need to have been completed within a specific time frame prior to an injection?
That is a good question. I'm just scrolling through our LCD, and I don't believe that there is a specific defined time frame, but I do want to, if the nurses that are on from medical review, if you guys do have a time frame that you look for, please, you can just, so again, confirm there's no specific time frame as long as those imaging that imaging information is included, and it does include that treated area and problem. So, that confirmed diagnosis, as we've talked about a little bit already.
All right, then the next question, when we bill the DSNRB, I'm not exactly sure what that acronym is, maybe and use the KX modifier, does this affect the limitation set for actual treatment?
So I think from not super familiar with that either, but I think it's diagnostic selective nerve root blocks. Is that what DSNRB stands for, to the person who put this in? Yes, okay. So let's see, when billing limitations for the set actual amount of treatment, I would not think it would. I would think that using the KX modifier would not have a effect on the limitations that are in our LCD. So I'm going to say no, but
I believe the use of the KX Oh, I'm sorry, Rachel. I believe the use of the KX
No.
modifier in this case is attesting to the fact that you have the documentation on hand and that this service continues to be medically reasonable for this patient. So I agree that I do not believe that that would affect the limitations. If we find something different, though, we will send that out to the entire group, but I do not believe it does.
Yep. All right, thank you.
Yeah, at this time, I'm not seeing.
Okay.
Oh, I'm sorry. No, I'm sorry, Rachel. At this time, I'm not seeing any additional questions in the chat. So if you want to continue, if more come in, I'll stop you at the end.
Okay, sounds good. All right, so yeah, I'm not seeing any questions, so I will go ahead and close this out. And I want to thank you all for joining us. Hope to see you in future WPS education. And on behalf of myself and all the nurses on our call today, we want to thank you for joining us and have a wonderful rest of your day. You may now disconnect.